Small but mighty crowd. Thanks for coming. My name is Keith Rose, and I'm your moderator for this, our health program, which is our 41st event. That's over the last 6 years. This is the final event for the 21-22 series. However, we'll be back in the fall, don't worry. We have a program planned for September, and there'll be a little bit more information about that program later on. We're very pleased that you're joining us either here in the Midland Cultural Center, face-to-face. Nice to see some smiling faces because I know we're distanced enough. Some of you got your masks off, so that's great. It's nice that there's a Rogers TV audience at home and they can be watching in the comfort of an armchair. And similar to the people that are joining us online through streaming, whatever their favorite electronic device is. So, welcome all. Let me introduce tonight's three speakers in front of me here. Carla Evans is on my immediate left. Welcome, Carla. Carla has been living with HIV, and I'll say the meaning of those initials because I don't think we'll probably repeat it. Human Immunodeficiency Virus, HIV. She's been living with this virus for 5 years. As you can see, she enjoys a healthy life. And her virus at the present time is undetectable and therefore untransmissible. Vaughn Mallow, sitting in the middle there, is a pharmacist by profession who's always keen to learn and share new information, particularly when it comes to drugs. Vaughn's been here before. 2017, I looked it up. You haven't changed a bit, Vaughn. He was here for heartache when we talked about how to the new interventions with cardiac disease. He discussed the details of a lot of the new drugs for cardiac medication and how they altered the system throughout the body. So welcome back, Vaughn.
Thank you.
And Colin is the Associate Medical Officer of Health for Simcoe Muskoka District Health Unit. And Colin's back for his third time. I don't know, is this good behavior, bad behavior, Colin?
You had a gun to my head.
So, Colin was here in 2017 when he talked about vaccinations in general, and then in 2021 when we specifically talked about the COVID vaccination. That was in March 2021. Tonight we're looking forward to hearing your comments about antivirals, the next step needed to fight viral infections after vaccination. I'm glad vaccination came first. So welcome to all three of you.
Thank you.
Thank you.
We have an electronic brochure. If you didn't have a chance to download it before, you can go home and download it, and you can see the biographies of our speakers listed in there and learn a little bit more about them as well as our next program. Before we start, I have some collective thank yous. The Health Advisory Committee, there are some of them in the audience tonight. In fact, I think most of our committee is in the audience tonight, and the one that isn't here is in spirit anyway. So put up your hands so we can see who you are. Good. Okay, great. And the person that did the organization behind this event is Kathy Wolfer. Kathy, thank you very much. This was a labor of love, I know, but you've been working at this almost 3 years, I think, Kathy, so good work. We have 7 local sponsors who make sure admission is free for all of us. I'll acknowledge them just a little later in the program. And I can't go without saying something nice about the extraordinary staff here at the Midland Cultural Center, Michelle, who does all our promotional material, and Glenn, who's hiding up there behind the lights, looking after our audio and visual and everything else you do, Glenn. Thank you for doing it so well. The other person that's kind of missing from the floor here tonight, if you didn't notice, because the cameras aren't here. Well, you think the cameras are here, but the cameras are watching. The cameras are in the corner now, and so this is new technology from Rogers using the in-house camera, but it all goes back to the same feed, ends up in the same place, and the same wonderful pictures. So thank you, Josh, for orchestrating that and putting it all together, and I'm sorry we can't say thank you face-to-face because you're hiding up there in the booth. Thanks, Josh. Thanks to all of you. The format during the first hour plus, we're going to engage in a discussion with the speakers like we always do. Some of you sent questions in advance, and I'm going to incorporate some of those questions into my discussion with each of the speakers. I am going to encourage the speakers to ask each other questions during their presentations. This is a discussion, an open format. I think the audience likes it better because it's just not so polished, not so perfect, which are sometimes kind of boring to listen to. So let's have a little variety, ask each other questions. This topic is complicated, though. It takes some concentration, particularly on some of the drug issues. So if anybody has trouble following, if you want us to slow down, just put your hands up, and we'll back up a little bit. So do that for us, please. That's the great thing about having a live audience. There's some absolutely immediate feedback. So look forward to doing that if you need to. So I have just a short opening comment. The primary objective of tonight's event is to provide you some basic information about drugs we call antivirals. Antivirals have been around for quite a while. They're not new drugs, but they're complicated, and particularly as we look at new viral infection, they're a fascinating group of drugs. I find it truly amazing that in my lifetime, I've been able to observe the changes these drugs have made in the fight against HIV. In the 70s, when we were growing up, HIV diagnosis and subsequently AIDS was essentially a life sentence, that people died. Similarly with hepatitis B, chronic hepatitis B, 10% of the population got sick, and a lot of them required liver transplants. It was problematic, and same with hepatitis C. We have revolutionized the treatment of those three diseases. Those people are alive today, and it is absolutely wonderful technology. So I'm happy to have seen that. Today, they're even being used for COVID, and you'll hear a little bit about that, although this is still in its probably infancy, if that's fair to say. But if you've been listening to the news today, there's a rock star by the name of Justin Bieber who's actually taking antivirals, and not because he wants to, but he's suffering from a facial viral infection. He has shingles in the facial nerve, essentially chicken pox in the facial nerve, so there's something local for you to hang your hat on, and he's benefiting from the antivirals. Carla, at this point I'm going to open it up to you. Okay. Tell us your story. Tell us what you'd like our audience to know.
I'm thankful for ARVs, for the antiretrovirals. I'm Carla Evans, and I'm a bookkeeper in Aurelia, and we have a family business. My father does taxes, and I have my boyfriend who's on board with us, and he's a financial advisor. And I was diagnosed May 4th, 2017, and it was the last thing on my mind. I hadn't had any symptoms or anything, and I only went because my partner at the time had tested positive for HIV. So I subsequently tested positive as well. It was a fairly smooth process. My initial fear in the beginning was, of course, like anyone else. The last thing I remember about HIV was when I was back in high school. I was diagnosed at 45 recently. I'm now 50. And so the last thing I remember was in the 80s when people were passing from AIDS. And it scared me. I initially went into shock and panic and just utter despair. I had the health unit reach out to me, of course, with a positive diagnosis. And the lady I spoke to, Mary, she reassured me. We spoke for an hour and a half, and she reiterated everything, how far HIV has come in the world today. And thanks to the ARVs, the antiretrovirals, people are living a lot longer. And actually we're learning even more because as people live longer, living with HIV and aging healthy and aging with HIV has become a whole new area that we can learn from and talk about.
So Carla, I actually talk about antiretrovirals as antivirals. Am I mistaken on that, or is this a very specific classification of drugs?
I can address that if you like. It's just one area that drugs target the HIV virus and limit its replication.
Okay.
That's one area. So
Okay.
that's a good
Should I
segue,
use the
Keith.
term retroviral? Should I use the term antiretroviral? Should I use that term or?
And antiviral is fine because it's still an antiviral, yeah.
Thank you. Okay.
Okay,
Carl,
thank
sorry
you.
to-
Thanks. No, thank you. So once I had my diagnosis, at first I didn't want to be open and share about it. Obviously, there's quite a stigma attached to it. And then afterwards I thought, it's actually something I'm okay with. Like, I take like I said, I was diagnosed much later date. I take my 1 pill a day. It's as if I don't even have it. I don't even think about it. I think half the battle is making sure I'm diligent in taking my pill every day. There's new injectable drug now that is out as well, and it's, what is it, bi-monthly? Yeah, bi-monthly, I believe.
Once a month or
Yeah.
even potentially just once every 2 months.
That's right. Yeah, so those are some options that I had, but my med that I was initially put on, Genvoya, has worked really well for me. It's limited my side effects. I don't really have any problem with it, so I'm going to stay where I am, and I'll wait. And I have some friends that have started the injection, the once a month injection or the bi-monthly injection. So for me, my most important idea or thing I want to get across with living with HIV is that it's not a death sentence. And if anything, the stigma is harder to live with than with anything. I think it's more difficult for people. So by getting the word out that by taking my pill, it's not affecting me in any way. It's as if I don't even have it. My blood gets checked every 6 months, and I'm at undetectable levels, which means I can never transmit that virus to my boyfriend. So that's really important to me and important to him. So the importance is my adherence to meds. I worry about the accessibility of meds for people that aren't able to go through the system as well as I did with my diagnosis. I reached out to every group, and anything that I could attend or virtually attend through YouTube or the Gilbert Center in Barrie was my first contact. And then I went to some women's groups in Toronto just to help wrap my head around it and learn a little bit more. So that's important to me. And I think anyone that has to take any kind of daily medication can benefit by having reminders, or at the pharmacy you can get blister packs to help with that med adherence. I have a text that goes off every morning at 11 a.m. and I don't unclick that text, so my little red dot stays there until I take my pill. And like I said, it's very manageable. It hasn't affected me, possibly maybe a little bit of weight gain here and there with my meds, but other than that, I live quite well, quite free, zero restrictions, and no issues with my health.
But think when you're recounting this plan that somebody put in place for you 5 years ago, of looking that the plan was in place for people who have suffer from new viral diseases where the process isn't worked out, because this has been like clockwork. Have there been surprises along the way, or is it like, have people been able to be at your appointment? Are things happen as they're billed to happen, or has there been confusion?
Well, other than the initial shock of the diagnosis, it was actually quite smooth. I'm not sure if there's a process out there, but when I was diagnosed by my family doctor, it then went directly to St. Mike's in Toronto, and I had an appointment there, and they knew exactly what to do. A pharmacist, I had a social worker to talk to, I had I just had an entourage of people and information there. So I felt like it was really smooth in my process. I'm not sure how that is in other places, but speaking to the handful of people I have, it was a really smooth transition from diagnosis onwards. No shocks. My biggest problem was obtaining an affordable way to be able to have my monthly meds, to purchase my meds. So initially, the consensus was ODP. So I'm a self-employed bookkeeper. I don't have benefits. So initially, I stopped working anyways, and I went down to Toronto, relocated down there, spent probably about the first 4 months, probably closer to 6 months, getting my head wrapped around everything and finding out what avenues I had to go down. So initially I was on ODSP, and that took away my stress over the meds available, the accessibility of the meds. And then from there I was able to regroup and rethink about access to my medication. So from there I was able to go on the Trillium, and yeah, that's worked really well. And in a lot of cases, I wasn't aware of this, but you can actually have your med company cover a deductible. So I didn't know that at the time. So that was really nice to know, and that was a relief. So once I had my head wrapped around that, how I can keep taking my life-saving meds, med, singular, it was a much easier process.
And is somebody still paying for it, or are you paying for it?
I still have the deductible covered by the brand of my company.
Okay, so the deductible's covered. Is that
Correct.
still a challenge for you to meet the rest?
Not as of yet.
Not yet. Okay.
Yeah.
Okay. All right. Any idea if you didn't have insurance, what it would cost, Carl?
Oh yeah, I want to say, if I remember first off, I want to say it was $1,300 a month for my Genvoya.
Yeah.
And so my initial shock was, oh my dear Lord, how am I going to handle this? And that was actually my biggest fear. And then after that, once I got myself under control and figured that path out, it was so much easier to be able to deal with the diagnosis. And like I said, now I just like to speak out on it and let people know, so that now breaking that stigma is what I'm working on.
When you're out talking with people, you obviously meeting with other people that also are HIV positive. Any lessons learned from them that you want to share with us, or are their stories often similar to yours?
I consider myself a newbie to the HIV diagnosis. So actually some of the circles that I've since joined, it's actually heartbreaking and gut-wrenching to hear the long-term survivors that have dealt with this, and my heart just breaks for them. And hats off to them. They've overcome a lot of hurdles that the rest of us, anyone being newly diagnosed, is kind of like, whoosh. You know, it's a lot manageable and less stigmatizing now. And the more that they get out that U equals U, the undetectable equals untransmittable, the more that information gets out there, the less stigma there is on people that still don't want to be open about it because of that, because of family. I've had a great support system, my whole family right from the get-go, and I said I'm going to be open about this, and they were all great with that, and had no problem with me speaking out and bringing our name in there, and because it doesn't just affect me, it affects my family, it affects my kids, it affects my boyfriend, for me to speak out publicly, and we're good, and we need to get that information out.
Yeah, thank you. Colin, Vaughn, any questions for Carl or any comments?
My question is, what's the injectable drug you're on?
Sorry?
What is the injectable drug that you're receiving?
Cabenuva.
Cabenuva?
Yeah.
Okay, I do not know that. So I won't be talking about that today, but that's intriguing to me. Is it just a subcutaneous shot, or IM into the muscle?
Yes, I believe it is.
Yeah, I think it's just an IM long-acting, just lasts a month or two, so it makes it a lot easier. Not everyone likes the one pill, although one pill is not that many.
That's
Really?
right.
I think, back in the day when they were taking AZT as the first medication, they had to take it 3 times a day. The side effects were just horrible. I'm sure you've heard about that from previous people, so.
Yeah, my one pill has 3 ingredients, and the Cabenuva has 2, I believe.
2, yeah,
Yes.
that's right.
But you're very compliant, so the injectable might be suitable for somebody that's less rigorous in setting their clock
Yes.
at 11 o'clock, right?
Yeah. Or, if you feel stigmatized taking that pill.
Yeah.
If you're not out about your status, and yeah, it can be stigmatizing, but
Okay. Thanks very much, Carla. We'll come back. We'll come back.
thanks.
Vaughn is going to use a PowerPoint presentation because this is complicated, and he felt that an example would walk us through it a little more easily. So, Vaughn,
I get to
talk
take it
to us
away.
about
Okay.
this group of drugs called antivirals.
Okay, I will do my best. First off, I must pace. It's just a nerve thing in front of people. So I'm a pacer. So my job here tonight is to try to convey how these wonder drugs actually work. And it's interesting because at first I thought, well, wonder the definition is almost on two opposites of the spectrum here. Because some of you and people in the public are probably wondering, well, why don't we have more antivirals? Well, why can't we get them faster? And what's the problem with them? Where are they, right? Especially with COVID, why can't we have a drug right away? Well, it's difficult to develop an antiviral drug. A virus is a tough target to hit, okay? It generally floats around your bloodstream in this impenetrable shell, okay? And we haven't developed anything that can target that shell. Once the virus is in our cells, once it's infected our human cells, it actually uses our human cell machinery to rebuild itself. So there's no way for us to attack our own cells in order to prevent the replication of these viral particles. It's difficult to do, okay? The next problem is just sheer replication. Like a Hepatitis C virus can redevelop 10 trillion virions a day. 10 trillion. It's a number you can't even fathom, okay? And the other part of this is obviously time to drug development. These drugs don't come out quickly, and of course, when drugs do come out, resistance appears and rears its ugly head and makes it difficult again to establish another drug that's going to be effective.
So, Vaughn, is resistance to antiviral drugs as big or a bigger problem than antibiotics? Because we've been talking about antibiotic resistance for a long time, but it's very specific.
Yes.
Is it much more common with antivirals, or tell us where we're at?
I'm going to say the antibiotic resistance is a much more problematic issue in today's day and age. I'm very aware of the overuse of antibiotics in the environment, in the world, in agriculture and aquaculture. So I'm going to say it's more of an issue than antiviral resistance at this point in time. Although we can't play down the importance of resistance to antiviral medications.
It's an important issue for Carla. She started talking.
It will
about
be very
resistance.
important for Carla.
She doesn't want to go there.
Nope. I'm happy with my one, and it works well, and I'll stay with my one because I only have so many meds that I can choose from. If I build up a resistance or a tolerance to my med, and it's no longer working to attain that undetectability in my blood, then I have a few more I can go to. But I'm happy with my side effects, and everything at this point works well. So I really don't want to. It works well, you know. If it's not broken, I don't want to have to fix it.
Yeah, let's not fix it. I hope so. There are options out there.
There are.
And you'll hear about them.
There are other options.
So, let's see. The first antiviral drug really came out in 1963. Okay? And since then, we've developed at least 90 more that treat a variety of human viral illnesses, from hepatitis B and C, HIV, herpes simplex, RSV, influenza. Okay? The interesting thing is, so back in the 70s, you guys can correct me. I'm not making fun of your age, but you can
I'm the
correct
only
me.
one that probably remembers that on stage.
One of the first magical antivirals was a drug called acyclovir, and it was developed to treat herpes simplex viruses. And the great thing about this drug was we could give it to people, and it would target the virus and minimize side effects to the host. Okay? Fantastic. It was like a pivotal event. So on the heels of that discovery of acyclovir, I'm going to bring in my props. I went out, special for you guys, and bought some RNA and some DNA. Now, RNA and DNA is kind of the building blocks of human life, plant life, animal life in the world, everywhere. DNA is also a viral particle. You can have RNA viral particles. Now, DNA and RNA each contain 4 nucleic acids, stretched up and down in a manner. DNA is a double helix, RNA is not. So, what acyclovir did was he said, okay, I'm going to take one of these nucleic acids, I'm going to chemically generate a substitute, it's a fake nucleic acid, make it into a drug, it'll get absorbed, delivered to the target cell, it'll substitute itself into one of the other nucleic acids, and that causes the problem. all of a sudden this little chunk of DNA doesn't know how to replicate and just dies. So the virus dies. So that's how, in this particular case, we killed off the herpes. Well, we didn't kill it off. We developed an accessible, minimal side effect type treatment for herpes simplex virus. Now, so move on through the 70s. The 80s to me, in my age, I was 13, et cetera, 1980. AIDS was big in the papers then. And it was this new virus that took the world by storm. And it actually took antiviral research by storm as well. We were behind the scenes. We had some ideas of what to do with the acyclovir development. And we worked on that same kind of thinking. Okay. HIV starts out as a little piece of RNA, okay? But HIV is interesting, and you've heard the word already, because HIV is what they call a retrovirus, okay? So it comes in with this RNA particle, but the first thing HIV has to do is through this enzyme called reverse transcriptase, it turns itself into DNA. And then this DNA goes into the nucleus and gets interpreted and basically repackages, recreates more virions. So the first drug they developed was called a reverse transcriptase inhibitor. So this enzyme that took the RNA and made the DNA, we figured out how to block that. And guess how we blocked it? We said, okay, there's 4 nucleic acids. Let's make a fake nucleic acid, plug it in, and shut down the reverse transcriptase enzyme and prevent the production of our HIV DNA. And that worked. And that first drug was called AZT. I think somebody mentioned that, which was great. So everybody thought, hey, fantastic. Let's make some more of those. So they made DDC. They made 3TC. Similar drugs, similar modes of operation on how to prevent replication of HIV. The problem is resistance. Resistance developed quickly to single-agent AZT. They started combining therapies, okay? And here, I'm just going to get into my slide program. So Glenn, if you can pop that up, and it should just pop up on the screen behind me. Soon, right? Is Glenn on break back there?
Here we go.
Okay, so essentially, we knew enough about the viral life cycle, okay? I want to make it simple for you to understand. So I want to put it in the context of, say, an automobile manufacturing plant or some kind of manufacturing plant. So here we have a picture of a semi-truck backing up to the outside of our plant. That's basically the virus docking itself on the cell, okay? And HIV, the virus docks on, I believe it's T lymphocytes, right? Mm-hmm. So it attacks those kinds of cells. So the next thing that happens is, well, if your truck's pulling up to your automobile plant, it's got stuff in it, necessary supplies to build products, well, it dumps it into the plant, and these products become unpackaged. Same with the DNA, the viral RNA. It's dumped into the cell, it becomes unpackaged, and it exposes basically the blueprints. DNA and RNA are the blueprints for rebuilding future virus particles. Okay? Now, transcription is a process where basically we read the instructions of these blueprints. Okay? Transcription occurs in the nucleus of our cells. So here I simulated this with just a bunch of engineers reading blueprints in an office. That's like the nucleus of your cell. Okay? So they're reading blueprints. The DNA of your cell is being read as well. And these messages get sent out to the assembly line. Okay? The DNA is interpreted, the instructions are sent from the nucleus out to the cell, and it says, build me these proteins because I need to make new cars. I need to make new virion particles. All right? And the last slide is basically all the copies. Okay? So essentially we have the virus come into your cell, it injects this DNA. DNA gets unwrapped, the blueprints are exposed, it goes into the nucleus, they get interpreted and basically say, hey, cell, make proteins for me so I can reassemble another virus particle and exit that from the cell so I can go infect others. Okay? Now, that's basically my slideshow. That's it. Right? So this is what we're doing.
We're expecting a great big bad blob to come out that's the antiviral now. So tell us where the antiviral comes into all of this.
Okay. Now, well, maybe I'll play with this a bit more. Glenn, if you can leave that up. So the antivirals that we're looking at now, we do have viruses, antiviral medications that block the translation or the assembly of these viral protein particles after the information has been sent to the assembly floor. We have medications that block the interpretation of the blueprints or the reading of the DNA virus or the RNA virus. Okay? We have medications that block that. The DNA and RNA that kind of gets dumped in there, well, it's sitting there, it does its job. And I'm going to go back another slide to the beginning, because we also have medications that block the attachment of the virus to the cell. Okay? So we can block the virus getting into your cell. We can block the way the RNA is built into DNA in the case of HIV with reverse transcriptase. There are medications called integrase inhibitors, because with resistance, the medications I'd mentioned earlier, well, some of these HIV DNA particles escaped that drug, and they did their job. They went into the cell and they said, okay, I want to build me another HIV DNA genome. So to do that, the viral DNA has to incorporate itself into our human DNA, right? For our human cell processes to rebuild things. It does that by something called an integrase enzyme. So we made integrase inhibitors. So this piece of viral DNA, if it bypassed our reverse transcriptase drugs and gets to our nucleus for transcription and translation subsequently, we've blocked that. So this DNA can float around all at once, but it can't get into our human DNA, so we've prevented that. Okay? And then there's medications called protease inhibitors, and they break down any polyprotein precursors that were built as from the messages from the DNA. Okay, so a strip of protein may be built from the instructions that the DNA laid out, and these proteins have to be cut up into individual building blocks. It's like handing your grandchild a straight piece of Lego, all connected, and said, okay, build me a dog and a porch. Well, you've got to cut that straight piece of Lego into little bits so they can be reassembled. Okay? The process of chopping up that DNA into little bits is governed by proteases. And if we can block those proteases, well, there's no little bits. So we can't rebuild a new virus particle. All right?
Vaughn, one of the questions that was sent in to me, and perhaps this is a good time to, as you go through this process, was how many tries does it take to get an antiviral that works? So you have to try 100 times to get one to work, or is it more than that or less than that? Approximately.
Probably more than 100 shots, I would say.
And how long does that take? How many years does that take?
Well, HIV emerged in the 70s. AZT came on the market in 86. And we are still making effective medications to this day. And how many years ago was that? 40?
Yeah.
Roughly 40 years ago. So from the advent of the first antiviral to where we are now, we're about 60 years in. Okay. The stunning science and detail of study that has gone into development of these antivirals is just unbelievable to me. So anyways, that's HIV. So we'll move on to hepatitis C. Now hepatitis C, just a piece of RNA, right? No problem, we can handle that. The RNA follows the same processes, gets in the cell, but it bypasses the nucleus. It doesn't have to go to the nucleus. The particles kind of get built in the apparatus in the cell. Anyways, okay? So what did we do? We figured out where those enzymes were involved in reading the message from the RNA to build those proteins. NS3/4 inhibitors, NS5A/B inhibitors. They're all protease inhibitors. So they basically stop the RNA molecule from creating its building blocks. So we shut down the virus again. Okay? There's been many of those drugs developed in the last 10 years, 10, 15, well, I guess since the 90s, right? They've been studying how to do this. Ribavirin, PEG interferons as well. Although I'm not aware of their clear mechanism of action. But the protease inhibitors are specific, kind of called the direct-acting antivirals, because they directly act on a process that the viral RNA has to undergo in order to reproduce itself. Okay?
So with hepatitis C, if that's where you're on, didn't it take a long time to even find the hepatitis C virus, or which one there was? Because I think there's more than one.
That'd be a good question. I'm going to defer that to
Yeah, I mean, I think
Dr.
the hepatitis C story, I think many of you will remember, was by the time they discovered it, when they discovered it, they didn't have a good test for it, and it went undetectable in our blood donation system. And there were a number of people who got infected there. They did it, they went as fast as they could. They managed to get a test for it. And yeah, some of these viruses, unfortunately, we don't have a test for it until we discover it. I mean,
Yeah.
I think the classic example that we all living is COVID. It's actually quite incredible that we discovered the virus and we got a test so quickly. And we hope that there aren't any more alphabet hepatitis out there. There's hepatitis D, there's hepatitis E as well. But we're still far from Z, so that's a good news.
Yeah.
Sorry to interrupt you.
No, that's fine. Good question. And so that's hepatitis C. So how did we get hepatitis C down or restricted to the point where you have undetectable viral loads as well? HIV, you can have undetectable viral loads. Essentially, these products are more potent at doing what they do and shutting down certain functions within these replication processes. And there's more of them. And there's different ways of going about shutting down these viruses. So yeah, you can have patients on combination products, right, that actually produce zero viral load detectable. And it's fantastic. That's HIV, hepatitis C. There's some hepatitis B as well, but that's sort of better managed with vaccines. There are some treatments for the hepatitis B. The trick is the dance. There's a delicate dance between efficacy, side effects, and resistance. Okay? You heard Carla talk about the fact, she's on the Genvoya, her side effects are minimized, resistance isn't there at the moment. She's dancing the dance, She's living proof that the science has worked over time. It has taken time and it continues, okay? So quickly, I'm taking up too much time here. I'll jump to COVID-19. So there's a couple of medications we use. In a hospital, there's an IV medication called remdesivir. So if you come in acutely ill and your oxygen requirements are climbing, you may be eligible to receive this remdesivir. They basically stood on the science and the genius of others who lived through the HIV days of studying viruses and HCV and knew, okay, what can we look for? We have a better idea of where to go to try to shut things down. And remdesivir is what they call a polymerase inhibitor. And basically the remdesivir RNA has to start building itself, there's this polymerase that kicks everything off. And if you can inhibit that polymerase, well, you kick off the rebuilding of your virus. That's essentially how it works. Now, who here has heard of Paxlovid? Okay, so what is Paxlovid? Anybody? I'm asking. I know. Anyway, well, it's a new oral antiviral. It's the first oral antiviral that you could take to treat cases of COVID-19, right? Manufactured by the same company that came out with the first vaccines. It's a dual combination product. Okay, it contains a drug called nirmatrelvir, and nirmatrelvir is a protease inhibitor. So now you can tell your friends how protease inhibitors work, and actually, the COVID virus comes out as that hockey stick with the Lego, the long piece of Lego, and the protease inhibitor cuts it up into little bits, so those bits can be rebuilt together into new virion particles, and that's how it works. It's a protease inhibitor. It contains a second drug called ritonavir. Now, ritonavir is something that can be used for HIV, but it doesn't really have antiviral properties. The ritonavir is a hepatic enzyme inhibitor. It just means it stops the metabolism of the drug nirmatrelvir in the liver. So this nirmatrelvir can stay at sufficient concentrations in your body.
Makes it hang around.
It makes it hang around. And actually, the medication Carla is on, Genvoya, contains two of these reverse transcriptase inhibitors, a nucleoside, a non-nucleoside. It contains the integrase inhibitor, and it contains another medication which acts as one of these liver enzyme reducing drugs. So it just boosts the concentration of the existing antiviral medications in the product. Okay? And that's all I've got to say. So hopefully everybody knows
I've got
how
lots of
antivirals
questions
work.
for you, Vaughn, but the
Sure.
one that I think could be most interesting to our audience at this point is you talked about that balance between resistance, efficacy, how well it works, and the side effects. But you haven't told us anything about the side effects of this medication. Looking at Carla here, we're not seeing any side effects.
She looks really
This is
good.
a well-honed
I'm very happy.
that she's on. But how about the antivirals for COVID? Are there side effects? Was that a challenge with them?
Oh, geez, that's a good question. A lot of the side effects I was looking at were the side effects of the HIV meds, the HCV meds. COVID medications, liver enzyme elevation is one of the side effects remdesivir can have. Rashes sometimes. Paxlovid I do not have a lot of experience with, but not as opposed to a side effect, but a potential drug interaction effect, is this enzyme inhibitor that is in the Paxlovid medication itself. That can interact with lots of other medications patients may be taking, and it causes problems when prescribing.
Because correct me if I'm wrong, one of the challenges with the COVID antivirals is the side effects, and people have been reluctant. Unlike you've talked about the vaccines with minimal side effects, antivirals. Now, correct me if I'm wrong, Colin, do you have some information?
Yeah, I mean, I think, if we look at the two COVID medications, as Vaughn has mentioned, remdesivir is a medication that we use intravenously. It's going to be used for hospitalized patients. Unfortunately, you can't rely on it when you finally get to the ICU because it actually does increase your chance of dying. Once you get there, in the hospital, in the ICU, your chances of dying, if you're taking remdesivir versus no medication, it's about the same. Mm-hmm. But if you're lucky enough not to die, then it does save you a few days of hospitalization. So as Keith had mentioned, your best way to prevent death is to get your up-to-date immunization, because we know that decreases your risk of death by over 90%. If you look at Paxlovid, it's great. It's oral. You don't have to, and it's targeted for someone who's the walking wounded. You're not needing to go to hospital. It does well in decreasing your risk of hospitalization. It decreases the risk of hospitalization by about 80%, I think, versus someone who doesn't take it. The problem is that there are, as Vaughn had mentioned, that there's so many interactions with common medications that people who will take the who are eligible to take it. So people who have medical conditions, those are the people who will do better with the medications because they have a higher risk of hospitalization. That it makes it difficult because some people are taking some blood thinners because they want to prevent their stroke, but then if you take the Paxlovid, it might change the effectiveness of that medication, so you have to weigh that. So it is a bit of a balancing act.
So this really corrected my naive approach to this. I thought, because I haven't had COVID, I would just get my doctor to prescribe me some pills that I would have at home, and as soon as I wasn't feeling well, I would just take them.
Yeah, I
Not
wish,
quite that
I
simple.
wish it was that, and it really takes a very skillful, physician to try to explain. I've spoken to some of the physicians, and they're like, I don't even know how I would counsel myself if I had to take it, because it is difficult. But what we're hoping is that because this is early days, we've had much less experience with this, and with more experience, they'll be able to just figure out which are the more important interactions, and maybe even fine-tune the medication a little bit. Also say for COVID medications, we're still at its infancy, and with the way that COVID's able to replicate and change so quickly, I think the future is we're not 100% sure we're going to get out of this just using medication, but fortunately, we do have a vaccine, unlike hepatitis C, where we don't have a vaccine.
Or HIV. No vaccine.
Or HIV, but
Yeah.
I'm confident we'll get one in your lifetime. There's been a lot of work going on, and it's because of all that work that you are in the unenviable position of having no side effects and living as long and as a high quality of life as someone else. And in some countries, people who are living with HIV, like in South Africa, who are taking antiretrovirals, they actually have a longer life than someone who doesn't have HIV. And you might say, well, why is that? It's because they're actually plugged into the healthcare system. And, so there are other sort of ailments that we all are going to get, high cholesterol, maybe heart problems, it's taken care of. So in those countries where, in South Africa, it's 20-25% of the population, that population who have the antiretrovirals, they're finding they're actually living healthier lives. So it's incredible.
It's a good time for you to segue into your discussion with us, Colin.
Yeah, that was perfect. I thought you said that up deliberately.
So
I was really impressed.
Being the final speaker, I have the advantage and disadvantage. They've talked about pretty well everything I want to talk about. But I am going to touch on a few things. So we'll start with HIV. I think what we have now is a slew of very effective medications, and we're not just using it for people living with HIV. We're using it for a number of other ways. One is if you are inadvertently exposed to someone with HIV, and this happens once in a while, more so before, but not as much. If you're in the hospital, you're working with someone with HIV, you're giving some medication, you accidentally poke yourself, there's medications you can take that will be 95% effective to prevent you from being infected. You can use that also for sexual transmission. If you have a sexual encounter and the condom breaks and it's a new partner, the partner was too bashful to say that that person has HIV and hasn't reached on the undetectable level, you can take medications to prevent transmission. And then that's called post-exposure prophylaxis. And then there's pre-exposure prophylaxis. I think for most of you, this might sound really weird, but there is, a group of people, albeit very small, who have a lot of sex, who don't use condoms. And you can do whatever you want to try to, get them to use condoms, and it's just not their thing. But we don't want them to get HIV, because if they do, it's costly, and they can also transmit it. So what we do is, for that very small group of people, they can take 1 pill a day, Truvada, which is 2 antiretrovirals, and that will prevent them from contracting HIV if they encounter someone with HIV. So, and then of course, with people living with HIV whose viral load are undetectable, they can't transmit it sexually. What we're finding is, at least in Canada, we're finding that the number of new infections have actually leveled off and starting to come down. That's the good news. The bad news is that it's still there, and fortunately, I think in women it's starting to go up a little bit, whereas in the traditional higher prevalence groups, in men who have sex with men, that has gone down. So we still have a little ways to go, And, the eventual cure is the vaccine. But at least in Canada, we have antiretrovirals. We cross our fingers that we won't encounter resistance. That's why they're taking 3 or 4 drugs. It's just to make sure we kill the hell out of, pardon my language, the virus so that it's unable to develop resistance. So that's HIV. For hepatitis, just start off with the basic, very, very basic message for hepatitis A and B. If you don't know if you're immunized, go get immunized. It's like the most effective vaccine ever. So for most of you, you may not have got hepatitis B if you're older because it may not have been developed at that time. But certainly for your grandchildren, maybe even for your children, if they went through school in grade 7 in as early as 1980, they would have got the shot at school. It's a sexually transmitted infection in general, so that's why we give it in grade 7. And it's also can be vertically transmitted, meaning the mother can pass it on to the baby. And it's quite infectious in terms of if someone in the household has it and there's children around, usually by the age of 5, 50% of the children would have been infected. So if you don't know if you've ever had it, just get it. Hepatitis A is another one, another completely preventable. I'm sure many of you have got it. It's the one where you look at the ad and they're going on vacation and then suddenly they have to go to the washroom and poo a lot. They have diarrhea. So that's like historically they've marketed it as if you go to Mexico or eat some bad food and you're going to get it. But in actual fact, you can get hepatitis A here in our country. So again, those vaccines are combined. You can just get it 3 shots and you're done.
So do you only have to take it one?
That's it.
That's it?
It's super, super effective.
Okay.
Yeah,
okay.
it's great. And Ron's right, hepatitis B, if you get it, they have medications, but it doesn't work that great. If you look at liver cancer, all the liver cancers that we have in Canada, I think that the number is something like 80% of all liver cancer is caused by hepatitis B and C. So, the effect of curing or preventing, first of all, hepatitis A and B, and curing hepatitis C, because we have a good cure, no vaccine, is that we can cut the number of liver cancers there. And of course, for every person who has liver cancer from hepatitis B or C, there's a number of people who have liver failure or cirrhosis or scarring from that. Hepatitis B, we're fortunate. I think if you get it, I think only 1 in 5 will have a chronic infection and can get scarring. If you look at hepatitis C, that's not so lucky. I have to look at the numbers here, but 20%, 1 in 4 people will clear the infection, but 3 in 4 will have, 75% will carry the infection chronically. And of those, 20% will get liver scarring, could get liver failure, and then they're about 100 times more likely to get liver cancer. So this cure that we have, that Vaughn has described, is really a miracle drug. It is 95% effective. You just take a pill a day for 8 or 12 weeks, and it's quite well tolerated. And all those people who had hepatitis C, who were, might get liver failure, liver transplant, or liver cancer, that all is curable now. The biggest challenge for hepatitis C really is the cost. I think it's like 50 or 60,000, maybe even more, for 1 course of medication. So if you're under ODB, ODSB, you're covered. If you are working for an employer who gives you a drug plan, you're probably covered. But I'm not sure if you are working very hard but not making a lot of money, but making just enough to be over that ODSB threshold, that's the tough spot of how you would get the drug. I know drug companies are giving it out because they have a responsibility, I think.
That's a naive question. I have the vaccine for A and B, so I'm not going to worry about it too much, to be honest.
You don't have to worry about it.
But hepatitis C, I don't have a vaccination. So how much do I have to worry about it, and what would the signs of hepatitis?
Yeah, I mean, the good news is that currently, to contract hepatitis C, if you're just a regular person doing regular things, you don't have to worry about it. If you're sharing needles, if you're using IV drugs, if you're using, sharing dirty medical equipment, if you're doing sort of underground medicine and stuff like that, then you have to worry about that. Our blood supply is completely clean.
Colin?
Hey?
How about a blood transfusion?
Blood transfusion is completely clean now because we have the test for it. There was only a year, albeit it sounds short, but it was a very long period of time where, a lot of people got infected because we didn't have a good test we didn't have a test for it. So most people who contracted their hepatitis C are baby boomers back in before it was discovered. People who were born from 1940s to maybe 1969 or so. You're born in that age group, it is worthwhile, if you haven't already, just to get one test done, just to make sure you weren't unlucky enough to contract it at that time. Because you could be asymptomatic and it might not show up. And if you're asymptomatic and it hasn't showed up, that's the time to treat it. So we've got really good medications for hepatitis C. The one thing I think I want to just say about, you talked about what does the future hold for antivirals. To be honest, we've talked about the best of the best, and I think what I'm truly concerned about, not only for antivirals, but for antibiotics, for infections in general, is there is very little business case for the pharmaceutical companies to pursue these drugs. That's the problem. That's a huge problem. Much easier to treat the acne, get a drug to treat the acne, to treat your hypertension, to treat your cholesterol. They're easier to do. The margins, the profit margins are higher, and guess what? You have hypertension for life. You take it forever. For infections, it's like a 5-day course, a 6-day course. And this has been a struggle the last 20 years. It's just that companies are less likely to put the research and development into these medications. And so what we need in the future, and I mean not the future, in the present and the future, is not just rely on the drug companies to do it, but the collaborations of universities as well as governments to ensure that the development of drugs continues. Otherwise, as you know, Keith, we have, very close to, we've seen pretty close to drugs that cannot, we don't have drugs to treat certain types of tuberculosis, certain types of gonorrhea. But that's my biggest concern. But we have obviously the know-how if we have the resources to develop those antivirals.
It's just amazing in hearing the three of you, though, talk about HIV, years and years and years, hepatitis, 10 years less, and recently with COVID, like 2 years in the making, we got some drugs. So, I think we should be encouraged of that acceleration of progress in science to get us there.
Yeah.
Yeah, I'm encouraged by the science. I respect it, but I'm leery of it because the vaccine did come out quickly. This first oral drug came out relatively quickly. We got to make sure that the evidence supporting these vaccines and these new drugs are peer-reviewed and validated to really glean their true benefit for a cost. There's other medications that we've been using in sick patients in the hospital, like Dr. Lee has mentioned, the remdesivir, he's right. It doesn't affect your overall survival, which annoys me from a financial point of view in healthcare. There's another drug called Tosolyzumab, which can be given to the severe COVID cases in ICU, and it doesn't attack the virus. It shuts down the immune inflammatory response. Very pricey, and not all that effective either. The data isn't great with Tosi, but yet it's being used and used and used. And sure, it sounds free. I don't have to pay for it at the hospital, but the healthcare dollars are coming from somewhere. So that's all I'm going to say there, because for me, that's a rabbit hole. I'm a little suspicious of pharmaceutical companies, but I do respect the science that's gone behind the products that are created. I know some of the companies have compassionate programs for individuals who can't afford medications, and patients can tap into those programs, and through assistance groups, et cetera, you can learn how to do that. So that is encouraging.
Can either one of you talk about how, if I felt that I had the symptoms of COVID and started to isolate, but if I look through the little booklet, it says you're potentially eligible for an antiviral, Paxlovid. How do I get it? Should I get it? What should I do?
Do you want me to try this
Yeah,
first? And you can back me up.
I think because we had a question come in about accessing it. And,
Okay. How should I say this? Okay, so if you've been vaccinated, if you're essentially fully vaccinated, 3 vaccines and a booster, Paxlovid's probably not going to do anything for you if you got your symptoms or you've picked up COVID. If you got 2 vaccinations, maybe it'll do something for you. And if you've got 1 vaccination, it should help you to some degree. Now, degree is what we're concerned about. How much is it going to help you? Okay? And so they've taken that sort of stratification and gone, okay, 1 vax, 2 vax, 3 vax, and if you've got this list of debilitating health effects, if you're on chemotherapy or immunosuppressive drugs, you're diabetic, you happen to be on hemodialysis, that ups your risk for a severe illness. Because Paxlovid is intended to keep you out of hospital. Right? It's intended to acutely decrease that viral load so that your immune system can overcome the disease. So if you're vaccinated for it, do you really need it? Right? So the word of Paxlovid goes out there, and it's this great drug, and it's the first oral drug that's, it's not a miracle worker. So if you're completely unvaccinated and you've got health risks, and I believe there's age stratifications as well, then yes, you will fit the parameters. But it's not as easy as, hey man, I'm going to keep some Paxlovid on the shelf, and when I start getting a bit sweaty and a cough and nasty sore throat, I'll just take these for the next 5 daits without consulting my physician about the other medications I'm taking, and end up in the hospital because I took this medication and then pick up COVID. It's anyway.
Okay.
All right, sorry.
Colin,
Yeah, no, I mean, I already told you how complex it is. So I think you have to kind of look at yourself. If you're older, if you're like, oh man, I'm getting older, I guess. I think if you're sort of, I guess, my age or older, so maybe 50, 60 and older, that, and the older you get, the biggest risk factor for COVID severity is age. It's not 50, it's probably closer to 60, 70, et cetera. So the older you are, the higher risk you are at. The more medications you're on, the more medical conditions you're on, I would like to ask the more at risk you are. So if you're on that trajectory, essentially the best thing to do is when you're feeling sick is to go to an assessment center. Because they are there, they can do the test quickly to assess whether or not you have an infection, and they will be well versed on the criteria. You can try your family doctor. I wouldn't blame him or her if they don't know, because it is so complex. I've looked at the algorithm. It is very, very complex.
And then it changes every 2 weeks.
Yeah, and that, it's just complex because there are so many interactions, and the original trials were done on people who had more severe medical conditions, and they're trying to bring that down
Right.
a little bit by extrapolating the data, by saying, well, maybe they don't need to be this medically compromised. Maybe they can be this. So that's why.
So one quick question
Yeah.
before I break for just a quick intermission. This has probably happened because it's happened so quickly, and the best we have is out there, which I think people are saying maybe isn't the best it could be. So how many years will it take, or what will it take? Do you see in my lifetime, your lifetime, of getting antivirals will be very good for these coronaviruses, or what do you think?
I have my doubts. I have my doubts because this virus just replicates so fast, so quickly, and changes so quickly.
Okay.
We had monoclonal antibodies that worked really well, that targeted a specific part of the virus, and within 6 months it was obsolete because they changed so much.
Okay.
I think the other example is we look at influenza. We've had the same two drugs for a number of years, and it it saves you a couple of days of symptoms.
Yeah, and their effectiveness is
Yeah. So
not great.
I have my doubts.
Okay.
So get up to date with your
vaccinated.
Thank you for being honest with it. At this point, it's my privilege to talk about our sponsors and about our next program. There's a slide of our sponsors. There's 7 wonderful groups here in the area. The best news about these sponsors is that they're all coming back next year for the 22-23 series, every single one of them. And to those of us on our committee, this is a tremendous feeling of support that they're subscribing to the program next year. So the 7 of them are Georgian Bay General Hospital, Anita Federici and her Psychology and Emotional Regulation Clinic downtown, the Hillcrest Village Care Center, a long-term home, the Lipton Group, a group of real estate and big companies that deal with a lot of things, construction, Mink Insurance, and Audia Hearing Aid Center, and the Waypoint Center for Mental Health. So to those 7 sponsors, thank you very much for all you do for us. Our next program is called Home and Health. What's home and health? Of course, home is healthy. No, it's about homelessness. That's what we're going to focus on, and the effect of homelessness on health. And I think you'll find it very insightful to understand just how big a problem this is, even in our area. We have 4 great speakers. Gordon McKay, who's the former mayor of Midland, who co-chairs the Housing Affordability Task Force here still, and 3 speakers from local organizations that look after people that are without a home. A gentleman from Wendat Community Programs, the director from Chigamik Community Health Center, and somebody from the guest house shelter. So all areas that are dealing with this, so I'm really looking forward to it. If you're having trouble figuring out, oh, this is so far away, well, it's exactly 3 months tonight, 13 weeks tonight, so September the 15th. So we'll see you then. Thanks very much. A couple of other reminders. There is a blood donor clinic here at the MCC on Saturday, August the 6th. They'll always welcome you. And the other thing is the Terry Fox Run. And I mentioned this early because you're probably getting plans, and it happens just after our next events. But on Sunday, September the 19th, there will be a Terry Fox Run throughout all parts of Ontario, specifically here in Simcoe County, the Terry Fox Run in the heart of Georgian Bay. So watch for their ads, watch for their brochures, and subscribe to it. They're a great organization. Thanks. So let's get back to some questions. Okay, we talked about stigma of HIV. How about stigma for infectious diseases in general? I can think back in my career when we put people in isolation and we closed the door. If that wasn't stigmatizing a group of people, and these people were hardly even sick. So how far have we come, and what have we done to change the attitude about infectious diseases?
Interesting.
Colin, you start, and then...
Sure. I mean, I think, infectious diseases have a history of being a bit selected to marginalized groups. I think TB is one where it spreads quite quickly in closed, crowded spaces, and closed, crowded spaces are usually in, places where there's not as much affordable housing, and everyone's cramped in developing countries. So yeah, so there has been a history of that. I think we've all worked very hard to try to put that aside, but we still see it. I see, people who are they come to see me in the clinic because they've just come in on a student visa or emigrated, and they, the immigration saw something on the chest X-ray. They come in and they are worried sick because they're worried that I'm going to find TB in them, and I'm going to just send them away. So yeah, we've had a history of that, and it is a big fight to try to not stigmatize it, because sometimes those infections just happen to be concentrated in those populations. It's nothing to do with them. It's so much as they have the factors that, that seem to facilitate that. And I think COVID is our most recent example. For lack of a better term, we were shutting people in their homes, right? I mean, I say it, if you're sick, stay home. Some people didn't have homes. Or some people were in 10 people renting rooms, and we had to try to facilitate that. They were very afraid because they were afraid that the landlord would kick them out and all that. So it is a consistent fight, and as healthcare workers, as the public health department, we really try to reassure them that we're not trying to stigmatize them, but it does take a lot of effort to do.
Any formal programs in the hospital organizations to kind of, I want to say welcome these people, and yet it doesn't seem the right word, but it should be in a way. But how do you create that openness feeling? We're glad you came, instead of, why did you come and see me? I might get it from you. I got to put my gloves on, put my mask on.
Yeah. We're not just Walmart screeners, right?
Yeah.
Meet the screener at the door. You were looking directly at me, so I guess I'm going to field a bit of this. Of course, being the hospital for the community, we welcome anybody who's ill. Bring us, you're sick, you're unhealthy, we will cure you, send you home as best we can. However, the discipline of infection control has evolved drastically, I would say over the last 2 decades, in terms of personal protective equipment, cleaning solutions, wipes, getting away from bleach and into all kinds of different kinds of chemicals that actually sterilize surfaces, or they call this will be called the fomite. This whole surface, if I touch it now, it's a fomite because it potentially has bacteria from my hands on it. And it can be used, if Carla touched it, she could touch the fomite and get my bugs. So extensive cleaning problems, and my hat's off to the housekeeping individuals in the hospitals everywhere in the world who have done an outstanding job under tough circumstances to keep the hospitals clean and healthy for the sick coming in. I can't say enough about them. Anyways, regardless, we do still have to isolate sick individuals. So we're not just talking COVID. I mean, stigma associated with COVID because you may have a COVID designation on your room or the door is closed. Everybody knows that's the COVID person. There's a germ called C. difficile in hospitals that we need to protect patients from and need to contain. And how do we do that when staff are moving freely in and out of these rooms to care for these individuals? Well, we've come up with systems where we may flag their door with pictograms, and the pictograms have certain images that mean translate information to the healthcare providers indicating, okay, I need to wear a mask, I need to have gloves on, I need to have a gown on. There may be a color code on top which indicates what we are isolating them for, which the public does not know. So it takes away some of the potential stigma. Yes, so that's what we do.
You're trying. Carla, any further comments on infectious diseases in general and stigma?
Yeah, I think during COVID, I probably felt the most amount of stigma than with my HIV diagnosis, because like you said, it was everywhere. As soon as you sneezed, it seemed that everyone was like,
yeah, got a long way to go. Okay. Here's a question that got sent to us. Will people stop getting vaccinated if there is an option to take a pill, to take an antiviral medication? Do you think that'll destroy the vaccination? I mean, look ahead, because I think we'd all rather take a pill than get a shot.
I think the more options there are, the better. I'm not averse to having like a nasal vaccine, a pill vaccine, or you take a pill a day like for pre-exposure prophylaxis for HIV. Whatever works, because we're all a little bit different. There are some people who don't want to take the vaccine for their own valid reasons, which, when I look at it, I don't necessarily agree, but I understand where they're coming from. And if we have an option for them, I'm perfectly happy.
Okay.
So yeah, I think HIV would be the example that we're bridging to the vaccine for some people who are really at risk by taking a pill a day.
Okay. Can each of you take a glimpse into the future 5 years from now? Where do you think we'll be? Will
Partying
there
like
be
it's
new viruses?
1999.
Will there be new drugs? Where do you think we'll be? Or is it just too early to tell? What do you think? Just a quick answer. Carla, where do you think it'll go, particularly with HIV?
Yeah, the vaccine would be lovely. I understand with the mutation that the cure would be quite a ways away due to the mutations of the virus of HIV. But the vaccine's a good place to start there. So,
Okay.
and like I said, they're close.
In your world, Vaughn?
In my world, what I see is a continuation of science into more targeted therapies for against viruses, with a softer side effect profile to all medications. That's the goal, right? And it's a good way to keep a drug on the market, because marketing a drug is not just efficacy. If you can take your drug and it kills you, well, you don't want to take it to eliminate the disease you had in the first place. So I just see more targeted therapies in the future, more potent therapies, and better tolerated therapies in the future. What I hope is to see cheaper therapies in the future, because the costs associated with these life-saving medications, to me, is disgusting, actually. But that is the pharmaceutical industry, or an arm of it, and it's a devil to deal with at the moment.
Colin, do you want to just reflect a little bit on lessons learned? So if you have another bad epidemic like we've had,
yeah.
what do you think we would do different in 5 years?
Yeah, I think, my life sort of 24/7 for the last 2 years has been COVID. And I think in 5 years' time, we're going to be living quite happily with COVID. I feel very confident that in the next year or two, we'll have found the happy medium, not only sort of individually, but as a society. We're not going to be as polarized, perhaps, as we have been maybe the last 6 months, where we're saying, I can't believe you're taking my freedoms away, and then others are saying, I can't believe you're giving them freedoms because you're not protecting us. I think we will find a happy medium. I think we're going to be, I said this after, I guess, SARS, that happened 20 years ago or whenever it was, that we're going to be better prepared for the next one. We might be better prepared, but the problem is the virus is always better prepared than us. That is the problem. We've gone through, in my lifetime, in the last 50 years, just 2 pandemics. One was the H1N1, and this was the COVID one. The first H1N1 was really a big pandemic, so this is the first big one. So I might be prepared for the next pandemic. I've only had 2 pandemics, unfortunately. But the damn virus has been replicating like crazy everywhere. So I think we will be better prepared. I think there's lots of lessons learned. But I think we can't kid ourselves. We're at the mercy of nature, just like we're at the mercy of climate change. So we can't be too overconfident.
Okay, thanks. I'm going to take just a couple of minutes before we have to close. Well, we've got 3 or 4 minutes to talk about some of the other diseases, other viral diseases, and common. So the one in the news these days, I says, is the one that, what's it called, that Justin Bieber's got, Ramsay-Hunt syndrome, which is facial nerve paralysis caused by the chickenpox virus. Tell us a little bit about it, because Bell's palsy kind of similar, and the pain from shingles is kind of similar. Talk to us a bit about it.
Yeah, so it's quite preventable, really. Maybe not for Justin Bieber, he just got unlucky, but for pretty well, I see all of you, it's quite preventable, and that's just get the shingles vaccine, the newer one, not the one that you might have got 10 years ago. It's called Shingrix. It's 2 shots. I think when I turned 50 years old and one day I got the vaccine because I've seen such bad disease from it. And because all of us here have had chicken pox, and it can come back any time. And in Justin Bieber's situation, it came on part of the facial nerve and also on his in his ear. But that vaccine, again, it's a miracle vaccine. There's very few vaccines in the world ever that work very well in older populations, and the Shingrix is the one. And that will prevent shingles from happening, which will prevent Ramsay Hunt and the pain of shingles.
Good. We've alluded to flu a little bit. Predictions for this year? Do you think people will go out and try yet another flu shot this year?
Yeah, I mean, I think flu's always with us, and as it's predictable, it kills like 500 to 2,000 people a year. It can be quite serious. I think we still should routinely get our flu shot. It's not the best vaccine, but I don't. When you drive up the 400, or when I drive up the 400, that seatbelt might not save me every single time, but it sure is better to wear that seatbelt. I think what is in the future, and we hope is in the future, is 2 things. One, they're working on a universal flu vaccine, meaning one that will cover more variants and maybe only have to do it once every couple of years. Second of all, I think they're also looking at combining the COVID vaccine and the flu vaccine at the same time as well.
It's funny you mentioned that. That's what I envisioned in the future for the flu vaccine. The COVID vaccine will just become, we had different variants last year. It's going to be in this shot this year. And
yeah, so hopefully they can combine it all. But flu's always going to be with us.
Okay. There's a question here that came in about monkeypox. So 150 cases in Canada now, something like that. It makes more news some days than COVID, which killed 1 million people in Canada. 1 million people, something like that. It's not quite that much in Canada. And in the U.S., I think it was 1 million people it killed.
Yeah.
Maybe it's higher. So, but should we be worried about monkeypox?
I think for the audience, I don't think you have to worry. You can carry on doing your thing. I'm worried about it because we're trying to contain it. Because I'm in the business of containing large outbreaks, small outbreaks, and this is a small outbreak. It's concerning because if you get it, it can be disfiguring. You can get fairly ill with it, and if it spreads more and more, then we may have to make that decision whether to use a vaccine. The smallpox vaccine, as many of you remember, I still have my scar from Vaccinia where they used to scratch it 5 times. So I think for the average person, I think you go about doing your thing. You don't try to interact with people who look like they're ill, just like we all try to do. I think you can go about your own thing. I think for people who are currently in the core group of where the infection is happening, which is in the men who have sex with men, and I think they just got unlucky. It got started in a music festival where men of sex with men were attending, and then it spread, from there. For them, again, I think them trying to just try to take the precautions with sick-looking people, and we hope that by doing the contact tracing, keeping them self-isolated while they're infectious, hopefully that'll do the trick. We're also immunizing people around them with the smallpox vaccine, and hopefully that will help burn out
Okay.
the small outbreak.
So thanks for taking us through so many diseases. I didn't see any hands go up, so hopefully we didn't get too complicated. I'm not going to take questions from the floor tonight, but I'll take your question later and we'll figure out how to get it answered for you, okay? But I do want to, before I wind up, I want to say thank you to our audience here at the MCC, to those who are watching us from home, either on TV or online. I hope that the discussion tonight, which I recognize was a little more complicated than our usual style, met our objective and provided a good opportunity to learn about the science, to learn about the technology, and to learn about the huge efforts that are going into drug development for viral diseases. I found it fascinating, Carla, to hear your story about HIV and to think where that has come. And we're on the cusp with COVID. We're at different ends of the spectrum, but it sounds as though we're going to get there. I hope we've given you that glimpse into the future, which shows that there will be potential new treatments. And unfortunately, there will be new viral diseases and different viral diseases, and that is the nature of the infection. But it's been great to talk to you all. I would be remiss if I didn't specifically thank our speakers. Carla, you were so open and clear with us, living proof of progress, but also to somebody who's willing to give back and who wants to spread the word about how well I can live undetectable and not untransmittable. And it is great to have you here. Thank you very much for coming tonight. To Vaughn, who did his best to keep this straightforward. It's a complicated subject, Vaughn. Thank you for the pool noodles.
Yes,
Now
they
know the
were
difference
wonderful.
between DNA and RNA.
Isn't that a great piece of
Thank you,
DNA?
Colin.
$3.
And those 4 nucleic acids, and we got to have a fake
Yes.
one. Yeah,
Well,
yeah.
You got to
I was
understand
listening.
those, right?
Okay. So thanks for taking the time to prepare, Colin, to put your slides together. Nice simile of what the production was like of the thing. Thanks, Colin. Vaughn. And Colin, as usual, steady, interesting to listen to. You have such a wide breadth of knowledge, and you're not doom and gloom. You got a good outlook on it. It's always wonderful to hear you and to hear how you accept the changes, and even after 2.5 years of what you've been through, 24/7, as you say. So thanks very much for joining us, and I'm sure you'll be back. Thanks, Colin. To our 7 sponsors, thank you again. And 3 months from tonight, 13 weeks, Home and Health. We'll see you there at 7:30 p.m. live everywhere. Good night, everyone. Thank you.